Hello and welcome to today's webinar. We are continuing our installation of PPE from A to Z series today with N95s and respiratory protection. We're glad you're here. All right, so for those of you new to NETEC, we are a partnership for preparedness that aims to set the gold standard for special pathogen preparedness and response across health systems in the U.S. with the goals of driving best practices, closing knowledge gaps, and developing innovative resources. And by that, we mean that NETEC and the 13 RESPECT facilities, Regional Emerging Special Pathogens Treatment Centers, is a network of facilities that aim to be the resources for your region in all sorts of special pathogens care. So you can see the regions here. We're proud to have 3 new regions this year joining the base 10. And what does NETEC do? Well, we have 4 main functions here in consultation and assessment, looking at allowing facilities to do self-assessments to see where they are on their road to preparedness. We do on-site and remote guidance and also provide emergency on-call mobilization, which we hope you know and need. We do education and training, things like this. We have a whole list of webinars and continuing education providing resources for education online. We have a research network, and we have international partnerships, since this is a worldwide effort to be better prepared and to take good care of patients who might have special pathogens and the staff members who care for them. So today I'm joined by from some of our other PPE interested folks from across the country. So that is going to be I am Jill Morgan. I am from Emory University Hospital here in Atlanta, Georgia, and I am part of NETEC and part of the PPE working group. I am joined today by Brooke Henriksen from Providence Sacred Heart Medical Center and Children's Hospital in Spokane, Washington, where she is the training and education coordinator for Special Pathogens Program for Region 10 in Providence. And she's co-chair of the NETEC Personal Protective Working Group. We're joined by Ryan Thatcher. Ryan is with Corewell Health, and he's the clinical educator for the Corewell Health Special Pathogens Unit, where he focuses on training and educating the clinical team members to care for patients with high consequence infectious diseases. He's also a member of our PPE working group. And Angela Basha, who's from Nebraska Medicine. She's the director of isolation and quarantine programs at Nebraska Medicine. She serves as the director of the consulting services we just talked about with NETEC, and is the program director for their region's Regional Emerging Special Pathogens Treatment Center. She's also a scholar at their Global Center for Health Security at the University of Nebraska Medical Center. All right, so we're going to go through a few things today, and then we will do some Q&A at the end. And I'm going to kick us off talking about respiratory protection for healthcare professionals and really why we're here today. So I will say that despite being where we are in a waxing and waning pandemic, we still have a lot of questions about respirators, about respiratory protection programs, fit testing, medical clearance, the pathogens themselves and the risks that healthcare providers are in on a regular basis. And we are lucky to be informed by a lot of new aerosol research, which we're really grateful to have. I also personally want to do a bit of a mea culpa today because on the last webinar we did, I completely garbled my speech and basically said that that masks aren't PPE, and that what I was really trying to say is masks don't count as respiratory protection when we're talking about these small particles. So my apologies for misspeaking last time. I'm going to make an effort to be very clear about what we're talking about today. So first of all, why do we need respiratory protection? What are we talking about? Really, I think it's important to understand that we are producing these tiny, tiny droplets in just the condensate of our breath and everything that's coming out of our mouths. Sometimes more, sometimes less, certainly, but they can come from way down in our alveoli and all the way up through our mouth and oral pharynx. Those that are small can float on the air for a long time, whereas the larger droplets, the wetter, heavier droplets, tend to fall around us, and that can contaminate the surfaces around us. And while we're most thinking about COVID lately, I think for many of us, we're thinking about all the other things that can live on a surface for any length of time. And that could be something like RSV. So if somebody's coughing and they have RSV and it's landing on those surfaces, it's possible that those surfaces can become contaminated. A lot of what patient care we provide really requires us to be much closer to the patient than when people think about the risks to the general population. And it's important to think about this entire phase, right? That when we're talking about airborne transmission of viruses and other pathogens, really there's a person generating all of these little microbes, all these little particles, and that will depend, how much they're spewing out of them will depend on a lot of things. What is the viral load at the various sites within them? What's the size distribution of these exhaled aerosols? How much of the pathogen is in each of these little droplets? And then what happens to them in the environment? Are we using source control? Is it a very humid or a very dry environment? Is there a lot of turbulence in the air? How long can a virus stay viable in the air? And it's important to understand that as small as viruses are, they don't travel alone, right? They are encased in typically a mucousy, protein-rich little droplet. And that means that as that dries out, it might actually get lighter and float around longer. So there are a lot of things that affect the movement of these particles from one place, hopefully not into someone who's receiving them, right? And that depends on whether we have any protection on, where they get deposited, whether they can make it all the way down into our lungs, whether they get stuck in our nose or mouth. So there are many, many phases of this that we can interrupt. And I think that's one of the important pieces of this, is that there are ways to interrupt these pathways. So what kind of pathogens are we talking about? So in blue, we really have the things we think of as typically aerosolized particles, airborne, those capable of staying in the air for long times. The worst, of course, I think, as far as a risk of infection would be something like measles, but nobody wants to have somebody with chickenpox or disseminated zoster like sitting in their oncology waiting room. Many of us became acquainted with N95 respirators back when we were taking care of TB patients, or when that was our main worry. Certainly something like smallpox would require a respirator. Let's hope none of us ever see that. And we know that in times when our national security might feel at risk, we think back to times like when we had the anthrax scares and people were, worried about white powder and things like that. Those that are in that pale green are the ones that we think more about droplet precautions. And while we've talked about these things as discrete, droplet or aerosol, we know now that really that's just a continuum, and that all of these people produce small and large particles, and that we need to think about how we can protect ourselves, how close we are, how much time we're going to spend in that room, how much time the person's been in that environment, and the airflow within that space, so that we're thinking about reducing our risk at every level. Many of you are probably aware that the organization that helps guide the CDC's recommendations about PPE has been meeting over the course of this last year and is working on some draft documents to sort of change how we think about droplet and aerosol precautions. This is still a draft document, and we only have the very beginnings of this. And I will say that the pathogen-specific guidance, which is usually in the annex of this document, if you're familiar with the one that came out in 2007, the annex contains all of the pieces that say, for this pathogen, this is what we recommend, and that is still being created. So what we have is this idea that we would change to routine air precautions, special air precautions, and extended air precautions. And each of those would have some pathogens that go with it and some recommended PPE and engineering controls in terms of airborne isolation. So let's talk about for just a second what an N95 respirator is. Well, first of all, it falls into a group of respirators called filtering facepiece respirators, FFRs. And they are designed to reduce our exposure to particles, small particles of all different kinds. It's important that these aren't the same respirators that you would use if you were exposed to, for instance, some sort of chemical, right? But these are for particles. The N means it's not really resistant to oil. That's probably not a consideration for most healthcare uses, but in other industrial uses, that's why these things were classified this way. So N, not resistant to oil, R, somewhat resistant to oil, and P, strongly resistant to oil. And then the 95 to 99 to 100 of the airborne particles. But all of that only works if it fits right. We're going to get to that more in just a second. So all of these are filtering face piece respirators, and they're based then on this filter mechanism. Well, what does that mean? So how can a filter really get all these tiny particles and yet still let me breathe? And I think it's really an important point to talk about here, that these particles, and I'm going to quote a wonderful respiratory researcher, Lisa Brasso, who says, a particle is a particle. Whether we're talking about viral particles or we're talking about a particle of dust or dirt or you're sanding your car or whatever, a particle is a particle. And they have different mechanisms of getting through things. And this is why the fibrous particles of masks are sort of chaotic. They're not like a weave or a knit. They are layered bits of chaotic fibers that help interrupt the flow in between what you're breathing in and your face, in your airway. So there's inertial impaction. This is when they just slam into things. There's interception, when they kind of scoot by a fiber and they're attracted to it. Sometimes the fibers actually break things up. And then there's electrostatic attraction, where some of these things are charged particles and droplets, and they actually are attracted to the bits of the fibers in the mask. And really, procedure masks, medical masks, surgical masks, and N95s both have these kinds of non-woven, layered textiles. The difference really is how dense that weave is, and then also the fit. Both of these kinds of masks can have protection to your airways, but they have to fit. And so with a surgical mask, with a medical face mask, you know that they are sort of loose fitting no matter how you try. They're not going to make a complete seal. And an N95 is meant to be a tight fitting respirator. And that means that if you wear something that isn't tight fitting, air is still going to take the path of least resistance. And that means it's going to find a way in and out around that mask if either the filter itself is clogged, or if you're not wearing it appropriately and you've got gaps there. Nothing's going to force the air through that mask unless it's fitted to your face. All right, so that's just a very brief overview of what we're here to talk about today. And I want to introduce Brooke Henriksen, again from Spokane, and she's going to talk about fit testing options and considerations. Thanks, Brooke.
Great, thank you, Jill, and thanks for the overview. So Jill had mentioned tight fitting face pieces, which is what we're discussing today, specifically N95. And what I want to talk to you about is how do we know that we have the proper fit? I think most of us have been fit tested. There's a couple of different ways, and we'll talk about that here in a minute. But what is a tight fitting respirator? And it is exactly as it sounds. So if you're looking at the slide on this slide on the right side, there are the filtering face pieces, the elastomeric, and then the elastomeric full face. Those all have to have specific fit testings every year in order to remain compliant. So to know that you've got the proper fit, either the proper mask or the proper elastomeric. We're not going to really deal with elastomerics today, although we will mention them briefly, but we really want to focus today on N95s. So N95s just by nature are disposable. They should cover the mouth and the nose, and they are going to filter out particles like what Jill was speaking to, such as dust, mist. They can filter out some larger fumes, but it all depends on the size. So N95s are designed to take out particles that are 0.3 micron or micrometers or bigger. So just to give you an idea, viruses are pretty small. They're much smaller than bacteria. they tend to be 0.02 microns to 0.3 microns. Like let's say COVID. COVID, for example, is 0.125 microns in size. So these work well against COVID. Influenza is even bigger. It's 1 micron to 4 microns. So depending on which influenza. So just to say, we're getting the protection that we need from these filters. And then Jill has already spoken to the NPR and what that refers to as far as oil resistance. I do want to mention, I've heard this a couple of times with people. It's like, well, if we're getting filtering from fumes and I've got my N95 on and I'm handling a code brown, why am I still smelling the code brown? Well, because it does not protect you against gases and vapors. And I want to make that very clear. Just because you can smell some things through your N95 does not mean that it is not working. It is working. It just is not going to work against vapors. Vapors would need some of those elastomerics that are shown here on the page. And again, fit testing is required for all of the tight fitting respirators or the tight fitting filters. We will deal with PAPRs in a future webinar. And what I want to quickly say about a PAPR is they are by definition a loose fitting PAPR, which is why they are not required to have fit testing. But we'll deal more with that in the next webinar. So to remain OSHA compliant on any of our tight fitting face respirators, we have to have this fit testing. It speaks to the patient or to the employee's safety. We know we have to have a good fit, as Jill explained, to make sure that we don't have any air going around the filter. So if it's not going through the filter, you're not getting the protection that you need. Availability of supplies is also a big consideration, and we'll talk about some of that here in just a few minutes. And then I'm going to leave the cost portion up to Angie, because that is a very big topic. And so we'll dive into that here shortly. So for fit testing, we have qualitative, which I think most people are familiar with. That is, it's going to rely on your sense of smell, your sense of taste, or maybe it does create a involuntary cough, depending on what solution they're using. One thing I want to say about qualitative, it is maybe possibly more common than what we see, but if your person that you're testing has recently had COVID and they have impaired smell or taste, that is definitely going to affect your ability to fit test. Quantitative is an actual machine that measures the volume of air that is getting through that mask. So that's how it's able to tell you, do you have a good seal or not? One of the considerations with qualitative is certainly the machinery up front can be more expensive, but then you also, every mask that you test can no longer be used. So you're putting a hole through that mask, attaching it to the machine that is doing the measurements, and that mask can no longer be used. With qualitative, you can reuse that mask. So you've tested your employee or your personnel and they passed the test, they can use that mask for one use. Medical records, we talk about that. There does need to be a health questionnaire that is done. And when we're talking about how often does the health questionnaire need to be done, they're not really specific on the timing of it, but it does need to be done at least once. And then anytime there is a change in a healthcare worker's medical record that would affect their ability to wear a tight-fitting respirator. So fit testing, we know that it's probably one of the most important parts of our program, especially for N95s. If you are not fit testing, you cannot say that you're getting the protection that you're claiming. OSHA does require that we have different models available at different facilities, but we know with supply chain shortages, that can sometimes change. So if you are having a supply chain issue and you're having to change N95s, your caregivers need to be refit tested to whatever N95 model you have. And I know that can be a big ask, especially if you're an organization that has 1,000 nurses in it. So that there's some considerations there, but that you have to be fit tested for any new N95 that you wear. And then there's some questions I have seen. It's like, well, I found one that works. Can I just use the one that I have? And I think, at least for our facility, you cannot bring your own N95 in. You have to be fit tested to it. So if it's a model that your facility can fit test to, then that is possible. But I would guess that your facility is going to be needing to provide that for you. So some of these questions kind of get very facility and organizational specific. So this is just kind of a fun little thing. I know that when I was first doing N95 testing, I kind of had the idea that if you had facial hair, you could not be N95 tested. Well, this is an old version. This is the version that speaks to the mask that fits, like where it says clean shaven, it's just around the bridge of the nose and down around the chin. We know that there's other versions of N95 now. Halyard has the duckbill. So the duckbill mask may or may not, you may have more or less availability, but looking at some of the check marks, like through the middle third row, you've got, I did not realize there were so many different names of facial hair configurations, but I guess if you have a walrus mustache, you could potentially be fit tested for an N95. All that to say, the moral of the story, so to speak, is the sealing surface of the N95 has to be in direct contact with the skin. So if there's any part of the mustache or beard that is impinging or making a gap with that N95, then you cannot be fit tested for N95s. And I love some of these. The wet noodle one is, I don't know why anybody would have that, just because they would have to be labeled that they now have a wet noodle mustache.
All right, Angie Vasha is going to join us to talk a little bit about the operational and cost considerations of respiratory protection program, and specifically N95s and fit testing, and in sort of comparison to some of the other options. Thanks, Angie.
Thank you, Jill. Now that we've provided an overview of what N95s are, how they work, and how to use them, I want to detail a bit more information about the operational and cost considerations. As Brooke noted, when determining what type of respirators will be available for your healthcare personnel, it's important to take factors such as cost, availability, storage, maintenance, and staff utilization into account. We've taken a look at some cost calculations for both N95s and PAPRs to overview some of the considerations that may impact decision-making within an organization. So as you can see here, we have put together a couple of different ways of calculating costs. There are benefits and disadvantages to all types of PPE as previously discussed or mentioned in our A to Z series. So the key to understanding what will work best for you and your team and your facility is to better understand what is available. As Brooke noted, there are OSHA requirements for the provision of a respiratory protection program that includes access to proper equipment. So the implementation, purchase, and maintenance of these components are essential. The costs that you see displayed here were calculated using pricing that's available to the general public. So I want to caveat that this does not account for bulk purchasing or organizational discounts that you have through contracts. The underlying assumption that we used was that it was one full-time healthcare worker wearing respiratory shift based on a 12-hour shift model. As you can see by looking at this, we used a range of $2 to $4 for an N95 and about $1,400 to $2,800 for a full kit. These are generous calculations, so we did use the highest price, worst case scenario estimates with consistency across the loose fitting respirator paired with the PAPR and the tight fitting respirators. So as you can see by looking at this, the upfront costs are pretty similar. So for the implementation of a tight fitting respirator for one employee for a year, it's right around $4,000. For the implementation of a PAPR kit, it's right around $3,700, which is pretty similar. Where we start to see the difference is with the ongoing inventory maintenance costs, which tend to be higher when solely using disposable N95s, primarily because these are disposable, and as you get rid of them after each use, you have to continually upstock your inventory. Of note, these costs can change drastically depending on the number of healthcare personnel using respiratory protection, the volume of admission of patients requiring airborne or droplet isolation, and the type of PAPRs that you are purchasing. Right now, the recommendation for a PAPR filter changes can vary based on duration and the environment of care in which you're using them. So within a healthcare facility, you do have to have a written schedule that is part of your respiratory protection program, but that time period can change anywhere from 2 weeks to 6 weeks to 8 weeks to multiple months. It's really based upon the function of the equipment, and it changes based on the environment of care. This is intended to provide an example of how to start to break down costs. It is not necessarily intended to say that these are the actual costs that everybody will find when you start to do an analysis. We also know that cost alone is not sufficient to make a determination. So when looking at these models, it's recommended to look also into the learning curve for proper use, the amount of training that would be required for healthcare personnel to use these appropriately, accessibility and availability of supplies, as well as support services needed to maintain your inventory. As Brooke mentioned, there are two different methods for fit testing. There is the qualitative and the quantitative. Qualitative fit testing, as she noted, is the more common method. It's normally used and relies on the user's senses. The costs associated with qualitative and quantitative vary due to the amount of time that it takes to complete the test, as well as the supplies required. Organizations can also choose to outsource fit testing to an approved vendor or train their own staff to complete these tests. When determining the best route for implementation of a fit testing strategy, it may also be important to evaluate the supply chain, current respiratory pathogen outbreaks, especially since the quantitative method requires the use of a respirator, which is punctured to attach to the port account machine and then is rendered unusable. One respirator is required for each individual's fit test. We also want to look at the amount of FTE that it would take to maintain an internal program. There's no one right answer or one right fit for every organization. Everybody has different factors, different variables that you need to consider, but here are some of the items that I would take into consideration as you're making determinations for implementing and maintaining a respiratory protection program. So in addition to the obligations to provide a safe environment for staff delivering patient care, there is a financial incentive for maintaining compliance with all of these regulatory guidelines. You can see highlighted on the slide here that in the time period of October of 2022 through September of 2023, there were 189 violations noted during 96 inspections of facilities which were classified as either healthcare or social assistance facilities. These citations resulted in over $650,000 worth of fines, which were paid in penalties. This is not an insignificant number, and it also goes to show that in addition to having the obligations to protect your patients and your staff, this can have a significant financial impact on your operating budget if you are not in compliance. And just to reinforce this point, when we look at the top 10 most frequently cited standards across fiscal year 22, the Respiratory Protection Standard 1910.134 is the fourth highest with almost 2,500 violations in fiscal year 22. These are violations that could potentially result in staff or patient harm and can be avoided by the implementation and adherence to a comprehensive respiratory protection program that incorporates purchasing the adequate equipment for staff, implementing a fit testing program, training and education to ensure that all staff have the tools that they need to be compliant with the program. I'm going to turn it over to Ryan Thatcher. He's going to walk us through the details of N95 use. Ryan is a nurse educator who is part of the Corewell Health System and the Regional Treatment Center in Region 5, and we're looking forward to him walking us through the details of N95 use. Ryan, I'll turn it over to you.
Thank you, Angie, very much, and thank you everyone for having me today. I am going to do a demonstration of donning an N95, then we'll do a seal check, and then we will doff the N95. So first, I want to make sure you wash your hands. Obviously, I just washed my hands. And then we'll check the N95, make sure that it is appropriate and it hasn't been used yet, and that it is in good working order. Then we will put the N95 on. So we hold it. Let me see, I'll hold it up a little higher. You can see you hold it like this. Then you put the top strap above on the crown of the head, and then you put the bottom strap below the ears. And if you can see, just like this, give me a thumbs up if you can hear everything okay. Then once you have the mask on, you want to use 2 fingers to gently place this down. You want to make sure that you're not pinching at the top because that will cause an air leak. So nice and smooth, so it forms to your nose. Okay, so that's how you put on the N95. And then we will do a seal check. So there are two types of seal checks. Well, one type of seal check, but you do it two different ways, which is a positive and a negative pressure user seal check. So with a positive pressure seal check, you want to exhale with your hands over your mouth, and you want the air to not come out here. You want it to come through the mask. Then there's the negative pressure seal check, which is where you breathe in deeply, and what you want to see is the mask indent just a little bit. And it's going to be hard for you to see on the call, I'm sure. But what that does is make sure that the air is always going through the mask when you breathe out and when you breathe in. You don't want any air leaks here or here. What I normally see is if you push the nose piece and it's too pointed, you'll get air leaks that come out and blow in your eyes. Or if you have changes in facial structure, for example, sometimes you gain 10 pounds because it's the holidays, then you'll feel, sometimes you'll get a little bit of a leak on the sides here. So every time you put on an N95, you need to make sure that you're completing a seal check. You want to do the positive and the negative seal check. And the goal is no air leaks, so you do not expose yourself. If you cannot get it, the first seal check, make sure you go through and fit again, complete the seal check again. If it still doesn't work, you may need to be refit tested for a different N95 or use a PAPR. You should not go in the room unless you have a seal check that passes every single time. Okay, so to doff the N95, you're going to bend over slightly. Then you're going to remove the bottom strap. And then you're going to remove the top strap and dispose of it in the garbage, and then perform hand hygiene. It's really important to remove the bottom strap first. If not, the mask tends to flip down, and that's not very sanitary since the mask is the last thing you take off. Thank you very much.
Thanks, Ryan. Benjamin, if we can go to the next slide. Just details the user seal check. And this is a really important, as Ryan mentioned, doing a user seal check is super important as the last step. We know that many people do reuse respirators. So we'll get to some questions and answers in just a second, but no matter what you're doing, you want to make sure you're using a user seal check for your respirator right before you go into a danger zone. And the reason we take the one strap off before the other is if you keep the bottom strap on and you take the top strap off, the respirator tends to flip forward onto your chest, and nobody wants those cooties all over their clothes. All right, I want to point out that we have a lot of references here. We're going to go to Q&A, but we will have these slides available. As Jason mentioned in the chat, you will be able to get this webinar link slides. And there are a lot of great resources here. We have a couple other NETEC webinars that we have put together that are linked here. That great picture of the facial hair allowed or not allowed according to the CDC is there, but also the certified equipment list. So I know that many people have questions about whether some of the respirators they stockpiled are suitable to use. And so it's important to keep, and it's very hard to keep up with, frankly, because a lot of these are getting revoked. And I think that it's basically wanting to look at both the certified equipment list and the list of voluntary rescissions and revocations. We have a lot of questions always about KN95s, and while we don't really have a lot of time today to talk about that, there is a study here that evaluated KN95s. More information about HICPAC, at least the draft guidance thus far, and then some great articles on both airborne transmissions and a link to a really important document, which is the OSHA Respiratory Protection Toolkit, which we got a lot of the information that we quoted today about what's actually required is there in that toolkit. So we're going to try to address a few questions here. Ryan, I'm going to start with you. Tell us a little bit about reuse of an N95. So kind of what is the best advice about that?
So during COVID, we reused N95s a lot. So the best advice is N95s should be used as single use only. Now, single use only doesn't mean single patient only. It means I put it on, I wear it, and then when I take it off, I dispose of it. And that is really best practice. These are disposable N95s. But longer use, right? You can use it for the duration of several hours with multiple patients. Just when you take it off, it should go in the garbage. That's what our advice is.
Thanks for that. And I know that many institutions will have differing advice on that. And certainly supply chain issues do not hit us all equally. We know that some facility types had a really hard time getting adequate numbers of respirators. And as many of us are starting to struggle with pediatric facilities and RSV and adeno and other kind of respiratory pathogens, you may find yourself needing or being directed to reuse an N95. The most important parts of that, as Ryan said, is, are you able to get a seal check, right? If you can still use a respirator and it's not difficult to breathe through and you haven't had it actually physically contaminated, like with splashes or sprays, then it may be that your facility is asking you to reuse them. They are considered and are officially single-use disposable devices. So we're all sort of bridging this gap. And frankly, we're all hoping for better things to come in terms of respiratory protection. All right, we have a couple other questions here. One of the questions is about trying to get and keep staff of all kinds fit tested. So especially if your facility, like mine, has had a lot of agency or traveling staff, who's responsible for all that? And I want to direct you, there is an OSHA does have a bulletin out about this, about agency or contracted staff and the joint responsibility between their agency that hires them and your facility. There's some very specific guidelines for who is responsible for what and how you have to verify those things. So this is not a situation where you can just say, oh, they're not my employee, I don't have to worry about it. There are obligations for whoever's hosting those folks. I do want to go ahead, Brooke, I'm going to direct the next question to you, and that is about the current guidance for respiratory protection for COVID and influenza.
Yeah, so I know that there's a question that's come in. It's like, why are we using some masks for some respiratory viruses and some masks for others, or an N95 for another? And it does tend to be how virulent or how contagious, I should say, how contagious is the pathogen? And then how sick does it make the individual? So how infectious is it? What we're finding with COVID, if we're going to take, for example, COVID and influenza, COVID has shown and proven to be much more contagious than influenza. So it takes a smaller dose to get COVID than it does influenza. And we've also seen that it can make you much sicker. So people tend to get sicker with COVID than they do with influenza. And I just looked up a little bit ago, in 2022, the amount of COVID deaths that were attributed specifically to that bug was around 244,000 for 2022. But when you look at the same numbers, or for the same, not necessarily the same 12-month year, but for a 12-month cycle for the flu, it was around 4,900 of people that had deaths attributed. So it is a complicated question. We do know that masks work for influenza, and we know that they don't provide as good a protection against COVID. So that necessitates the N95.
Yep. And I would also say, and this is a really, I think, an important point, and I'm going to sort of segue into another question that we got asked. No one needs to know, or probably does know, what your individual risk factor is. And that might be that you have someone who's immune compromised at home. It might be that you have a child that can't be immunized at home, or that you live with an elderly neighbor, or you have an elderly neighbor that you take care of, or an elderly family member that you take care of who might have special, immune issues, no matter what it is, you can always wear more protection than is necessarily required. Keep in mind that what the CDC gives are the minimum requirements. That means that if you feel like I just am worried, I don't want to take anything home, I want to wear my N95, and you are part of a respiratory protection program, you are able to do that. But there are rules. It's not just that I can just bring in whatever I want and wear it whenever I want. As Brooke said, if you are going to, there is voluntary use, and it is covered within that respiratory protection program toolkit. So I encourage you to look at these things. If you are one of the people who might have at risk, you might be at risk yourself or at risk family members, then you need to arm yourself with the information and the tools that you need to ensure that you're being protected. Likewise, if you're taking care of patients who have a profound risk, whether that's in a NICU or a burn unit or an oncology unit or a bone marrow transplant, you might be asked to wear an N95 even when you don't have anything because of the risk of asymptomatic spread. And I think that's something we became much more aware of during COVID when we had everybody sticking swabs up their noses all the time. We realized how many people have asymptomatic cases of these pathogens. And I want to segue that into answering one quick question, if I can, about how we get people who might be complacent. How do we get them to take all this seriously again? And I would ask, if you had a staff member, let's just pick somebody in your head, you have a staff member who is not completing the checklist for a central line insertion, right? They're not making sure there's a full body drape. They're not making sure that somebody dried their hands. They're not doing whatever your bundle is for that, right? They're not doing all those pieces. My guess is that at your facility, that would be a performance issue because it affects patient safety, as it should. Do you take that same route when you're talking about something that affects their safety? Do we put staff safety at the same level that we put patient safety? Because we have to have staff in order to operate safely. We have to have, I don't believe there's any patient safety without staff safety. So I think this is a cultural issue. I think we have accepted a culture, and I'm admit to having been part of it for way too long, where we took it as a badge of honor that we would run into things without the appropriate PPE, or that we ended up with blood on our shoes after a trauma, or, whatever, or I have an ICU bladder to this day, right? All those things that we thought of as, made us superheroes in some sense, they were probably really bad ideas. And so I want to say that we have to start changing that culture. That people should be taking care of themselves. They should be concerned about what they're bringing home. And that we need to make sure that we're addressing that by saying, hey, that's an isolation you need to have on this. No, you can't just tiptoe into that room without a gown on. No, you can't just do, we have to make this important. And I think we haven't. So I don't think it's fair to say, oh, those people in the ER never wear their PPE, right? When really, we've never made that an expectation. So I think it's going to take time, and we have to really start somewhere. And I think that we have little tiny microcultures within our facilities, right? The ER, maybe night shift on the ER, maybe Wednesday nights in the ICU, there's that really mean person who works. We create the cultures around us, and we need to start creating a culture of safety for ourselves and our coworkers, because that's what's going to be best at keeping our patients safe. All right, rant over. Let's do other things here. All right. I'm looking at some of our other questions we've gotten.
And Jill, if it's okay, I'd like to answer that was just placed in the chat, and I wanted to answer it live. And it's regarding fit testing certification. So giving you the training that allows you to then conduct fit testing in your facility or in your area. And I wish there was very clear, easy guidance, but there is not. OSHA doesn't really spell out a certification or any regulatory training that you go through, just that you have the necessary training to be able to conduct fit testing. What I will say, it is also state dependent. So in our state, we tend to have a certification type process where you go through a class that tells you how to fit test. And I wish I could say that this is the same as it is everywhere, but for some areas, like if you're rural, you may just have to check with your state and see, does your state have a stance on it, and how do you get that training? For us in Washington, the training, I think it was a 2-hour class, and then you just need to conduct fit testing regularly, which I think is yearly. But I wish it were some simple answers, but when we start dealing with different state regulations, and even sometimes within the state, different county health departments, it gets complicated quickly.
Great answer, Brooke. Yes. From a federal level, there is no certification for being a fit tester. Those increased requirements may come at the state level, or they may not. So that would be very state dependent. So absolutely, I applaud. Someone in our chat sending a question was asking about making their own company to do this. Absolutely, people make disposable hoods for fit testing. That's fine. People are making companies that can go out and do fit testing. That's absolutely fine. Just making sure that you're complying with state and local regulations there. And that is one important point, I think, when we were talking about the metrics that Angie mentioned with the cost of these things. And she mentioned fit testing, and we specifically didn't include medical clearance in that because regardless of which respirator you're going to be put into, if you need a respirator for work, you have to have a medical clearance. So that applies to whether it's a fit tested, tight fitting respirator or whether that's a loose fitting PAPR. All right. I do want to answer one question. I'm gonna pull it up live here. There are people who will argue that masks or respirators can't stop viruses because of their size. And absolutely, viruses can be tiny, tiny, tiny things. As we mentioned, their different sizes. But a particle is a particle, and these things are respirators are designed to stop tiny, tiny particles. Viruses do not travel alone. They can't get out of our bodies alone. They're enveloped in all this stuff. So I think it's important to understand the difference between information people want and will receive and sort of the people who are looking for a perpetual argument. So I sort of like the strategy of what evidence would it take to change your mind about this? Because if the answer is none, then I don't need to have an argument with you because we're not going to change that person's behavior. So I think that this is one of those cases where I am really sorry that science is not better known, and that we still have so much that we don't know about transmission and what might be a reasonable dose or permissible exposure limit on some of the things that we get exposed to in healthcare. But it's not the same as like silica or one of the other things that we can quantify. These are really difficult things. And so we're just trying to do our best to protect ourselves and our staff members. So I think we sort of have gone over the PPE for COVID and influenza and the whys for this. So right now, the CDC guidance for COVID and influenza do differ, and we don't know yet what HICPAC is going to say. So that's just a question that those answers should come out sometime in 2024. We'll have a little better guidance than per pathogen as far as what is recommended, respirator or mask. Elastomerics, I think we do have a few healthcare facilities across the country that are using elastomerics. They are a tight-fitting respirator. They still do require a whole fit test program. And certainly if you're a facility that is thinking about this, there have been some recent NIOSH studies about elastomerics in healthcare, and full disclosure, we participated in one of those studies. And we actually found that staff members were quite willing to wear an elastomeric. They come in some really nice colors now, so I think that helped. It took a little bit of the big black gas mask look off of it. So we had some nice respirators to give them. It's a lot of questions about whether you dispense the respirator to each staff member, whether they check it out of somewhere. And it does bring up the whole issue of who's cleaning them, when are they getting disinfected, how are they treating them in between uses? Like, do they keep it for the day and do they wipe it down? Because the front of all of these things get contaminated. So there's a lot to the implementation of any of these respiratory devices. All right, current masking for COVID positive patients and PUIs, I will happily do that. I have it right here. I'm just coming up to 20th century by having two screens up, but it confuses me a lot. All right, so the current CDC guidance for a suspected or confirmed SARS-CoV patient is standard precautions plus an N95 respirator, a N95 or higher respirator, gown, gloves, and eye protection. I love face shields. To me, that's the best thing that came out of the pandemic, or face. I love how clear they are. For some of us who go back far enough to wear those terrible safety glasses, so much better than that. So I think that that's a really important thing, respirators and some sort of eye protection, precision sprays, which also helps protect your respirator if you do in fact need to reuse it. And then that would be for any suspected or confirmed COVID patients. All right, do we have any other questions that our panelists would like to answer? Let's see, that we might have. Certified equipment, fit testing. Oh, I do want to say one more thing, and that's that many people are struggling with this idea of how they can possibly get everybody that in their facility fit tested. And the requirement is not that everyone in your facility get fit tested. But an important part of the respiratory protection program, and this is, when I say respiratory protection program, we really are talking about, it has to be a written document. There are great templates online for how to structure your program and how to fill in all the required pieces. And one of the really important pieces is a risk assessment. That means, have you looked? Do you have EVS? Do you have maintenance workers? Do you have who would be at risk and what are they at risk for? It might be that some of the people you're currently trying to keep fit tested don't really need to be fit tested if you put in place some other either administrative or engineering controls. So for instance, you could say our social workers are going to just do something by telemedicine, right? I mean, I'm not saying I'm not advocating for that. I'm just saying that's a possibility, right? There are all sorts of things that you can do to say, this is how we've addressed this. But the staff who would come into some risk of an aerosol particle or aerosol transmissible disease need to be covered by your respiratory protection program and have the ability to wear a respirator of some kind. So I think first, making sure you have an adequate, accurate, up-to-date risk assessment for the roles in your facility is really important, because you may be, there might be some other ways of handling some of those staff members. All right, so thank you guys so much for today. I appreciate that there are so many people that want to do the right thing and that are trying to understand the requirements, and that really you guys are out there doing a tremendous amount of work still. And that does not go unnoticed. Please know that. At NETEC, you can reach out and get many of us by requesting assistance through what's called a TSS, Targeted Support Services. We do have online education, and there are links for these things. You can, if you feel like your facility, you want to know what it would take to get more ready for a special pathogen, you can look and sign up to receive the SPORSA, which is the Special Pathogens Organizational Readiness Self-Assessment. We also have other online resources. So we have an entire resource library. We have a NETEC blog that covers a lot of the most current outbreaks and SITREPS situation reports for current outbreaks as well. If you have specific questions, please know that you can reach out at any time. And those do come to us, literally, at info@netec.org, and just be as specific as you can about what kind of information you want, and we'll get in touch with you. And then we do have an e-newsletter. So please feel free to reach out to us. We really appreciate the dialogue. So this basically says we're here to help, and you can still send your questions at info@netec.org or submit a technical assistance request at netec.org. I want to thank our panelists so much. Ryan from Corewell in Michigan, thank you as our newest member of the Respect team, and for being such a good sport for shaving off his very attractive facial hair to model the N95 today. We greatly appreciate that. I don't doubt that his winter beard will be going back on, because it was like 0 degrees where he was today. Brooke Henriksen, thank you so much, from my partner in crime at the PPE committee, and then Angie and her great leadership at NETEC and UNC in Nebraska. So really appreciate you guys being with us today, and thank you all. And please reach out, stay in touch. We're happy to help. Good luck, stay safe, keep each other safe, and we appreciate the work you do. Thank you guys. All right, bye-bye.